So I'm really excited to be here. I think the first session was fantastic. I think you can all see how passionate everybody is about HS. And I think that what I really loved was that our patients were front and centre in our discussions this morning. And I think that our patients teach us so much, and I think why a lot of us are here. So what I'm going to try and do is cover pathogenesis of HS in 15 minutes, which is impossible. So these are my conflicts, and I will be discussing some off-label treatments because we only have one FDA-approved treatment for HS. So a couple of years ago when I first started getting interested in HS, I realised how little was known, and what we tried to do was to think about what's happening at the level of the skin and the disease progression, and what are the possible processes that could be driving that. So both at a high level and thinking within the skin at a pathophysiological level. And we actually published this review in the middle of this year in a really nice issue of In Seminars in Cutaneous Medicine and Surgery that was edited by Hayley Naik that covered a lot of aspects of HS. And I worked with two very talented medical students, Lauren Hoffman and Mandy Gias, who are both here today. And we really tried to think about all the possible things that could be playing a role in HS to give us sort of frameworks to start to think about how we can intervene. So I'm not going to talk about the parts that are published as much, but I will try to introduce them where relevant and then introduce some new data from some analysis and how this can help us with treatment, because we've got to bring it back to that all the time. So I think it's fairly well accepted that at the top of the hair follicle, where the apocrine gland drains, is where there's some sort of obstructive process. We know that HS happens in areas where there are apocrine glands. We do not believe it's a primary apocrinitis, as the name might have suggested. But there seems to be some sort of hyperkeratosis and obstruction at this special region where the hair follicle, the apocrine gland enters the hair follicle. What I think might happen now, and this is sort of conjecture, but it's the only way that I can think that it happens, is that it's like a balloon being obstructed at the top, but there's a tap still dripping into it. So the apocrine gland still drains, and the normal function of apocrine secretions is to be acted upon by bacteria that live in the hair follicle, and then for that to release a discharge that is our body odour. But now they're trapped, and where do they go? Well, if it just keeps growing and growing, it has to do something, and I think it bursts either out onto the surface of the skin or into the dermis. And then we have things in the dermis that shouldn't be there. So we have dermal keratin, we have bacteria that normally live around the hair follicle, and they colonise, and then that sets up some sort of inflammatory process and a secondary apocrinitis. So that's kind of what I think is what's happening in the skin, and now we've got to work out why and what we can do about it. So this is our diagram from our review, just trying to think about all the elements of this pilosebaceous apocrine unit that could be playing a role. And we came up with lots of possibilities just from the data that's out there. So could there be something different about the sweat, apocrine sweat? There's one transcriptomic study that suggests that there's a couple of sweat proteins that are missing. Could there be something that's happening at that very special region, that infundibulum? And there are some transcription factors that are present in that area only. Could there be something to do with the sweat gland itself? Could the receptors be more sensitive? There's actually a single nucleotide polymorphism in a particular gene that seems to control development of apocrine gland secretion. So all of these could be playing a role that lead us to some sort of final common pathway that we go down the HS path. And then there's gamma secretase mutations that have been discovered in some patients and families with HS. This is reviewed nicely by Pink et al, and John Frew is going to be talking later today about bringing us up to date with what these mutations might mean. They seem to impact on some pathways that are important in inflammation. And I just want to show you a poster that was presented at the SID this year. This is some work by Heidi Kong and Alice Chen. Alice Chen is from the NCI, and she was doing a clinical study using a gamma secretase inhibitor and for desmoid treatment. So because that pathway of Notch is actually important in cancer development. And and Heidi was on service, and she was called to see these patients, and she said, "This looks like HS," and they reported this. And they took some biopsies of the patients and showed that there were some cystic lesions within the skin. And Mandy has a poster here that I urge you to see, looking at other gamma secretase inhibitors and trying to tease out the cutaneous adverse events of those drugs. So this sort of study can give us a clue and reminds me why we all need to keep talking to each other. So one thing is to try and work out, once we've got this process of inflammation happening, what happens in HS? Why doesn't it turn off? The goal of the immune system is to restore immune balance, homeostasis. So we have a trigger, there's some sort of inflammatory process, and normally we should resolve that. And that's what happens in the vast majority of cases. But once HS starts, it's like that doesn't happen. So why might that be? And in our review, we proposed that there's a number of different possibilities, but I think we have some new data suggesting that biofilms might be very important in this. So to do this work, we collaborated with some people that had published, so several groups had published this paper. So this was ustekinumab in HS, you've probably all seen this paper, and they took some blood at the beginning and the end of treatment, and they reported a little bit of data showing some of the pathways that these serum results showed, but it was a little hard to interpret. So we asked Carrie Brodemichael and Kathleen Lee from Janssen if they'd share the primary data with us, and they did. And with Janine Block, we looked at the clinical response. And what we found, and this was in conjunction with Dr. Maite Suarez-Fariñas, a very good friend of mine, who was able to do some more analysis on this data for us with her team. And we found that there were 26 proteins in the blood upregulated and 35 downregulated. And in looking at that data, there's lots of different ways to sort of pass out data like this. Everybody that looks finds different proteins of interest, but many of the complement proteins were dysregulated. And I was a little bit surprised at this. So I went back to think about what does complement do. And complement is one of the oldest ways that we fight bacteria. It's evolutionarily, it's one of the earliest systems we had. And there's different ways that the complement pathway gets activated. So C3 is the central early part that gets activated, and then that drives C5 production. And what we found in our analysis was that many of the early complement components in this were downregulated, and C5 was up. So what does complement actually do? It's really important for fighting infection. And what do we know about bacteria in HS? So the cultures historically have often been negative or show normal flora. When they've been identified, they're often coagulate negative species or anaerobes. And if you think about your patients with HS, there's rarely frank cellulitis or tender lymphadenopathy. So, but the bacteria are there, and then more modern methods have been able to characterise these bacteria more carefully and shown that this blue bar is the anaerobes that are really playing an important role. But there's another really important concept in HS that I'm just learning about called biofilms. So these have been found to be present in the tracks of HS. And what are biofilms? So biofilms are this, it's a way bacteria grow and multiply, and they develop a protective coating to allow them to resist normal immune responses. And when I heard about this, people often describe the biofilms being slimy. And I was reminded of something that Bill Danby taught me called the invasive proliferative gelatinous mass. That was a mouthful. It was at the bottom of these HS tracks, and he said you have to get rid of that. And that made me think maybe he was talking about biofilm before I knew what a biofilm was. So I went back to think about what's happening in the lesions in HS. So when people have done immunohistochemistry and looked for cells and what type of cells are there, nearly every type of cell that's there can be identified as there. But when you look really carefully, many of them are neutrophils, and the next biggest category is actually B cells, so CD20, which I didn't quite know what to do with because I had been previously used to thinking about psoriasis where you don't have any B cells really that you can find. So then we looked at the HS transcriptome, and we did this last summer with a college student actually. He went back and reanalyzed some of the early published transcriptomic data, and what we were surprised at is that 50% of the top 100 differentially expressed genes in the skin are immunoglobulins. And again, I didn't quite know, what do I do with that? Why are there lots of B cells in the skin of HS lesions? And then there were some other differentially expressed genes that were not as surprising in the response of inflammation. So I'm going to try and put this all together, and this is sort of a proposed idea for why HS progresses, but we have a lot more work to do to work out if this is what is happening. So I think once the process of inflammation happens such that there's bacteria in the tissue and in the dermis, the but the bacteria can multiply and form themselves into a biofilm, and they release this protective substance that can cover their surface. They activate the innate immune system, so because we've got the body's trying to get rid of it, so they release cytokines. These three are everywhere in HS. They're in the skin, in the blood, and they draw neutrophils in to try and fight this. And then that drives, and of course we often find macrophages and dendritic cells in the same setting. Then complement gets activated to try and fight the presence of these bacteria. And then we get the recruitment of the adaptive immune response. So we get our B cells coming in and other antigen-presenting cells, and there are T17 cells that are part of this ongoing inflammation. We know that immunoglobulins can be measured in the blood. We actually published a small report showing that there's a polyclonal immunoglobulin presence in HS, and that many of the PBMCs, when they're taken out of the blood, they look exhausted. So they're not making the cytokines they should. So I think that there's some sort of, this is another mouthful, but it's ineffective, chronic, excessive inflammation. So it's an exaggerated immune response, and it just keeps going. And then there's many, in the transcriptome, there are many proteins, or the differentially expressed genes that should be being made into proteins that drive chronic inflammation and set up the process of scarring, which is different to some of our other chronic inflammatory skin diseases like psoriasis or atopic dermatitis. And so that's how we get our tissue destruction. So it's a very busy slide, but I hope that sort of helps to think about how it might be progressing. It's not quite like the one that Mark showed yet for psoriasis, but we're getting there. And Lauren Hoffman has a talk coming up shortly on some of the other serum biomarkers and what they might be, how they might fit into this paradigm. So the next part is to try and think about why do the patients get so sick? The patients with stage 3 disease really have evidence of systemic inflammation. So, whoops, I stole my thunder there. They have acute phase reactants, so CRP is consistently elevated. They have high ESRs, the immunoglobulins I've mentioned, and many cytokines can be measured in the blood. And we think that IL-6 might be playing a role here. IL-6, of all the cytokines that's been measured, it's the one that seems to be most consistently elevated in HS and is very closely related to disease severity. And IL-6 can do many things, and many of them we see in HS. So they can activate dermal fibroblasts, they can affect the liver to release acute phase reactants, they can cause depression, they can also activate T cells. So there's a lot of reasons to think that IL-6 might be important in driving this. And then I just want to take the last few minutes to think about how does this sort of pathogenesis work really inform what we do in terms of thinking about therapies. So I think we need to think about what's happening in the skin and adapt our therapeutic options that way. I think we already do this in a sense. We have algorithms based on disease severity, but I think as we learn more about pathogenesis, we can do that more specifically. So stage 3, we need to think about biomarkers. Can we measure biomarkers at the beginning of treatment and monitor their response over time? Can they dictate which treatment we should choose? We have some anti-inflammatory treatments that have had randomized controlled trials. Adalimumab is the only FDA-approved treatment, as you know, but anti-IL-1 and anti-IL-23/12 have been tried. And then there's other drugs coming down the pipeline, and I think Dave Louie is going to give us a talk on emerging treatments in HS this conference. And I just want to introduce an interesting concept. So I found out about this by serendipity, but Drs. Othmar Zenker and Susan Graff are here at the conference, and they presented this really interesting idea of anti-complement therapy at the EADV in September this year. And they used it's an intravenous treatment. They found at the end of 50 days of this treatment, the patients had a 75% high score response, and they were quite advanced patients in stage 3. So that's really quite impressive. And then what I thought was really interesting is that was actually sustained after they stopped treatment, which is a very interesting idea and sort of validates the idea that there is this complement activation that's important and maybe driving some of the inflammatory response. So in terms of stage 2, I think once you have tracks, we have to think about how do we prevent biofilms forming and how do we get rid of them. And I've had some interesting discussions with Dr. Jim Brackey from a small company in Minnesota called Hibernex, and they have a product that dehydrates the bacteria, the biofilm, and they call it shock desiccating. And he connected me with a physician in Texas that's tried this on a few HS patients, just sort of gently putting this product down the tracks, and had some success. And Marcus Gitterles, he welcomes anyone who wants to find out more about that. He's willing to talk to you. And this is certainly not the only anti-biofilm treatment, but it's an option to think about proof of concept. And then in terms of stage 1, I think we've already touched on this morning, but I think we have to find these patients and treat hard. And this commentary has already been mentioned as well. I think this is really important because in dermatology we tend to think if it's early disease, it's not as bad. But we've already seen that even early disease has high impacts on quality of life and other psychological effects, and we want to prevent them from going on to later stage disease when it's so much harder to treat. So I just have a couple of suggestions and thoughts on how we might do that. So I think the pilosebaceous unit does offer us opportunities. So there's a couple of case reports of botulinum toxin being used to target the sweat glands. We know what it does to eccrine glands. We don't know how it might be helping apocrine glands, but these were all quite successful. I think laser hair removal as a strategy early has not been studied in a sort of randomized controlled manner. And then there's a technology that's FDA approved for hyperhidrosis and hair removal called MirrorDry that actually delivers microwave technology to destroy. It was designed for eccrine glands, but it also appears to remove the apocrine glands as well. That would be very interesting to study. And then lastly, I think we see in some of the randomized controlled trials that there's very high placebo responses. So I think we really need to think about that and how do we capture that, because that might either prevent progression or even make our medicines that we do use work better. And you've already heard Zareen's excellent presentation on the relationship between quality of life and pain and depression, and we need to think about intervening to reduce those features. And then tomorrow I'm really excited that we're having our inaugural HS school, and to teach patients how they can help themselves and what they can do. And everybody's welcome to come and hear that, as well as the patients that I know are coming. So I have many people to thank, but I probably don't have many minutes. But I mentioned Dr. Sferinas. I love my collaborative discussions with Afsana and an NIH collaborator, Rafaela Goldbach-Mensky, my team at Montefiore, and when I was there, and Sonia, a wonderful HS nurse. Thank you.